Hello everyone. Today we'll discuss regarding the inhaler devices in airway disease. My name Dr. Mohammed Hafiz. So why inhaler device was introduced? It was developed within the last 50 years, which forms an integral component of COPD management and asthma management. The development of inhaler it's just been recently developed, starting from 1930s with jet nebulizer. Then over the 1941 the development of drug alluterine and MDI, which was developed in 1955. Then 1960 nebulizers were developed, and introduction of spacers in 1970s, and dry powder inhalers also in the same duration. The initial MDI was CFCs, which was banned in 1987, and in 90s breath actuated MDIs were developed, and in 2003 soft mist inhalers. The development of inhalers just developed over the last 50 years, as we have discussed. I'll be discussing in detail. So what are the two main categories of inhaled drugs? One is the bronchodilators. There is short acting and long acting beta 2 agonist and anti-muscarinic drugs. The basic objective is to relieve the symptoms of broncho obstruction. The second category is the corticosteroids, which reduce the airway inflammation to prevent symptoms of asthma. And you can include the third category as mucolytic agents, acetylcysteine. So what are the advantages of inhalation therapy? Which is less systemic toxicity, more rapid onset of action, smaller doses to be used, and better efficacy. Even with effective inhaled therapy, this asthma treatment is usually poorly controlled many around the world. What are the reasons? The prime reason will be insufficient instruction as well as ineffective guidelines, insufficient patient education, access to the healthcare and cost of medication, as well as poor inhaler technique. So delay in starting the inhaled corticosteroid therapy, poor compliance with the therapy, wrong inhaler choice and inhalation technique. These are all the reasons. So out of all these reasons and all these devices, the PMDI, that is a pressurized metered dose inhaler, is the most frequently used. But even after repeated tuition, many patients fail to use it correctly. This is mainly because of the poor education to the patients or poor patient guidance. Several improvements in MDI have been developed as a change in propellant actuation have resulted in improvement in lung deposition. Many dry powder inhalers, they are also easier to use. So here there's a graph which shows the relationship between aerodynamic diameter and lung deposition. We should know that particles more than 8 nanometers, they are mostly deposited in the in oropharynx. 90% is absorbed in this area. The prime objective is that the particles of the MDI or the dry powder inhaler should be less than 5 micron. If it is less than 5 micron, it is deposited in the tracheobronchial tree, and 1 to 2 in the alveolar region. If it is very minute, it's usually expired. So as we discussed, the respirable, the target should be less than 5 micron of a therapeutic agent that will reach the site of action. In the coming topics, we'll be discussing about the inhaler devices, spaces and holding chambers, common problem with the inhaler technique, and the actual teaching skills for the usage of inhalers. Thank you.